Okay, great. So today we're going to talk a little bit about calling consoles in the context of a few common GI cases. So why do we call a console?
So it's something we can't handle like, by ourselves.
Yes, is that a clinical question? So we have a medical question. There's something that's out of the realm of our particular knowledge set or skill set. Maybe this patient came in with an AKI, thought it was prerenal, gave some fluid, now it's getting worse, and I'm confused. Or maybe this is, I think this patient needs orthopedic surgery. I don't do that. I don't have my skill set, so I should call someone. Great. Okay. So we are going to start with a case. So we have a 55-year-old gentleman, Mr. Z. He has a history of cirrhosis and hepatitis B. When he came into the ED with hematemesis, his initial vitals, his temperature is 36.2, his heart rate is 121, his blood pressure is 95 over 55, pressure rate is 24, and I'm set 93% of room air. On exam, he is alert, he's oriented, there's a mild distress, just kind of looks uncomfortable. And while you're examining, he has a texture of witness hematemesis, that's 300 cc's of bright red blood. Heart rate are tachycardic, his abdomen is suspended with society, mildly diffusely tender palpitation, and he looks pale. What are you guys worried that this room has? Yeah, so he certainly has a GI bleed, and given his history of FC cirrhosis, maybe he has a variceal bleed. Variceal bleed quickly or slowly? Very quickly. Great. So here are his initial labs. White count is 11. His hemoglobin is 8. He was here a few weeks ago just for a routine outpatient visit. His hemoglobin is 10. Like 74. He here is normal for a B1 of 34. It's usually routine. Last check. His belly's at 5.1. 3.2 of that is correct. AC males are a little bit about 71 to 84. So I'll 1.4. So we're saying we think this guy has an acute GI bleed. What we're going to do right now, what are sort of the pillars of how we manage an acute GI bleed? Access. Great. What kind of access do you want? Yeah, what does that mean?
I'm going big on nitro-14.
Perfect. So yes, confusingly, the smaller the gauge, the larger the needle, to 16 or 18 gauge needles. Or central access is something like a tortoise, something fat and something short, not a central line. It actually has higher resistance and you can't process it. Great, so we're enjoying this guy. Should IV access, you get 2 18 gauge IVs, and then what else are you going to get? Blood, yes. Replace what is being lost. Giving him blood. While you're waiting for the blood, what else are you going to get? Great, fluids. IV PPI, great, how much? Excellent. And then what other specific medications that you consider in this patient given this history? Octreotide, great. Why do we give octreotide? Yes, it's a blanket vasoconstrictor. So we're trying to constrict all of these vessels that are dilated in someone with cirrhosis and portal hypertension. And someone also said ceftriaxone. What's the point of that? Great, totally agree. It's relatively immunocompromised, dilated blood vessels, increased flow to the lymphatic circulation. They can translate the bacteria from the gut into their bloodstream, in particular cause SBP, which is associated with significant morbidity and mortality. Do you give this guy fluids? You transfuse him with blood. You start an IV PPI and you start octreotide and ceftriaxone. Do you want to call someone? Yes. Who do you want to call? Yes. GI. Do you want to call them now or do you want to call them later? Now. Agreed. This patient is worrisome for hemodynamic instability. And as we mentioned, variceal bleeds are very fast. So you guys by now probably have already called a consult. All of you in this room will be calling consults. And a lot of you will end up on the other end of the phone as a consultant. So this is a skill that's kind of intimidating at first. And here's a framework you could think about. We actually every year this time of the year get some feedback from fellows and attendees on what they'd like to hear. So you should introduce yourself. You say, hi, my name is Sam. You should also, with your name, give your role. I'm a resident on Team Madison Evans, and I'm calling you with and say why you're calling. Are you calling with a new consult? Are you getting an update on an existing patient? And then what I always do after that is say, can I give you an MRN? Always consider what the person that you're calling is doing. Maybe they're sitting at a computer and they're just like looking something up and they have time. Maybe they're running around trying to see a patient urgently. And you need to give them information like where this patient is and what it is. So after you can give an MRN. And then I always start with the constant score. Very brief. So in this patient, they give a constant score, a GI, I believe, and then I go into the story. You know, this is a such and such gentleman. So why don't you take 30 seconds and with the people next to you, pretend like you're calling a consult and just say what you would say. It feels kind of silly to practice, but it can be intimidating. So just practice what you would say.
Yeah. My one is very close. I'm sorry.
Brazil, awesome. Okay, so you called, yeah, all the consults today. You called GI today and you told them that this was the correct GI or possibly or.
That's exactly it.
Well, not nearly as much.
Stop.
That's tough.
Yeah.
It's fine, then I'm gonna call you.
We're pretty concerned on this.
And were they?
I already know.
So
I came out.
And then they can start review while. If when you're calling our yard, they don't really care. And you're without. Like for all of the things that everything this person. So like who can get the evidence. Also, it's fine for you, like, intervene.
Okay, I heard some great consult calls from all three tables, so thank you. I think another thing to consider is how and when you contact a consultant. So a patient like this, we talked about, you call them now, right? It doesn't matter what kind of day it is. This is a medical emergency, call the consultant. Whereas maybe if this patient had like one episode of hematemesis at home, has a normal hemoglobin, has completely normal vital signs, and it's 3 o'clock in the morning, maybe you don't call the fellow. Just consider the urgency. Fellows and attendees are on call for a reason, and if you need them, call them. But just ask yourself, is this urgent? Will they do anything now or not? I think also, particularly with procedural consults, there's sometimes this hesitancy of, well, I don't know if I want to call because I don't think they're going to want to do anything. But I would encourage you that for procedures that you do, you should be the one that decides if a patient needs it. You should decide if a patient needs a thoracentesis, if a patient needs a central line, if a patient needs a paracentesis. But I don't do EGDs, and so ultimately I shouldn't be the person that decides if this patient needs an EGD or not. So if you're worried about the patient and you're even questioning if they need the procedure, I would call a relevant consultant. Awesome. And then I think another question that comes up is, well, I paid the fellow and they haven't called me back. Any of our seniors in the room, like, what kind of time threshold would you give for this person? When would you page the fellow again or try to contact somebody else if they didn't answer?
You know, depends like how hemodynamically unstable,
Yeah.
if it's with the lower blood pressure and you're like watching it, I would not give it much time. I would urgently replace it, like within like 5 minutes max.
I totally agree. I wouldn't give it much time. This is urgent. Whereas if you're consulting IEP to ask about like OPAT recommendation for 2 days for now, you could give them an hour. That we don't want to annoy our consultants, but we want to be appropriately, for lack of a better word, pushy when it's appropriate for patient care. Questions about this piece? Yeah.
Is there a way if you're doing like a text page
Uh-huh.
or like a pager to a pager, not an epic chat, and that's what they do.
Yes. Yes.
Can you remind me of the number system or something?
So if you are paging from Amion and it has a hyperlinked number, there's actually a drop-down menu that says urgent, non-urgent. So you can select urgent. The university nurses use a system of 123 or 911. So 911 means provider to bedside now. 1 means call me back in 5 minutes. 2 means call me back within 15 minutes, and 3 means call me back within 30 minutes, non-urgent or an FYI page. So that's accepted at a lot of our other hospitals, but it technically is a university-specific nursing policy. That if you tag page 911, you put that. Great. And then any of our seniors in the room want to let me know, when do you text a fellow or when do you page? Do you ever text a fellow for anything?
I go to my cell phone.
Yeah.
If I know them personally and there's someone who I feel like I have a relationship with, I will text or call them. Yeah.
Awesome. I totally agree. Non-urgent for people with whom we have an established relationship, I think it's generally okay. Our fellows here tend to be very friendly and helpful, and that's the culture here. But I'd say if you have any doubt or hesitation, or especially if it is urgent, you page. Okay, great. So, yeah.
When you're, giving relevant clinical, is it better to err on the side of if they have questions, like, or say everything, so that.
Yes. So it's always a balance. I would say there's not clearly a right answer. I err on the side of giving less information and being prepared to answer.
Okay.
I also think fellows have told me to tell at the beginning of a consult what the consult is for, like 1 to 5 words for this patient for a GI bleed, so that they can frame in their mind when they're listening to me and then asking relevant questions, as opposed to not saying anything about the patient and just being like, Mr. G has history of blah, 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 and he's on these medicines, and it's taking a long time to get to the question. They can also know the urgency of like, I want you to stop talking now and I'll be right there. Or let's talk about this for a while. Great question. Okay, next patient is Miss S. She is 32. She's got no known medical history. Her sister actually went up to her house today because she hadn't heard from her in a couple of days, and she found her down and altered. On arrival, her temperature is 37.1, her heart rate is 105, her blood pressure is 104 over 66, her respiratory rate is 28, and her O2 status is 94% on room air. On exam, she's drowsy and she's oriented to person only. The sister says this is very unlikely. Unlike her, she is usually completely with it. Heart sound, she's tachycardic. She does have labored breathing, but her lungs are clear. Her abdomen is soft and non-distended, but when you push on her right upper quadrant, she winces. She is warm, she has bounding pulses, and she appears jaundiced. And her sister also noticed that and says that that too is unusual for her. She's never seen her like this. And here are her labs. What do you notice? Great, her transaminases are elevated. So we are writing as AST on the left, ALT on the right, so both are in the thousands. What else is that going on? Great, for weight, just a little bit up to mildly disease. Yeah, the bilirubin is elevated 6.3 and 3.3, that's correct. I'll process a little bit up too. What are you worried about in this patient? Toxic ingestion, cholangitis, great. Awesome. So what else do you want to order right now? Tylenol level, right? Tylenol level is ordered, it's pending. Top screen, great, the order review top. She has an ultrasound, it does not show a clot, it just shows diffusely abnormal epidemic hepatic parenchyma. Blood gas, okay, great, she's a little bit hypercapnic. Ammonia level, great, you order that and it's pending. INR 2.2. What do you worry about now? What overarching diagnosis? Liver failure. How do we define acute liver failure? Great. Yes, greater than 1.5. What else? It has to be acute. How acute's acute? Yeah, it's actually really long. It's less than or equal to 26 weeks or half a year, 6 months. But if someone comes in with elevated liver enzymes, usually predominantly hepatocellular, but can also have cholestatic pattern along with that. They're encephalopathic. They have an INR greater than 1.5. And as far as you know, they have no history of liver disease. They meet criteria for acute liver failure. Are you going to call someone? I see nods. Who are you going to call? GI, hepatology, great. This brings up a good point. All of our hospitals are different. The university is extremely specialized. And so there's luminal GI that scopes people, and there's therapeutic GI that does ERCPs, and there's hepatology that takes care specifically of hep patients. Here, there's a GI fellow that does all of those things. The VA generally is the same too. So it depends a little bit on where you are. You're either going to call hepatology or GI. Now we're going to wait. I see enough. 2 o'clock in the morning. Is that summer one thing? So this is a unique scenario where even in the setting of hemodynamic stability, this is an indication for urgent listing for liver transplant, and you should call them now. And actually, if this patient were here, you wouldn't even want them to stay here because you cannot get a liver transplant at Denver Health Hospital. You have to go to the University of Colorado Hospital. So you actually have to transfer this patient in the middle of the night. And hepatology would want to hear about this patient even if it's 2 o'clock in the morning. Great. Okay. So going back to calling our consultant, what are you guys going to say? We can do this as a whole group now. Anybody have what they would tell GI? Awesome. Hey guys, this is Sam, hepatologist.
Hi Sam, thanks for taking the consult tonight. This is an urgent consult
Okay.
for acute liver failure.
Oh, okay. Yeah, tell me what's going on. Of course. I'm ready.
Okay. This is thing was this has this is Miss S. She presented with acute liver failure with an INR 2.2 ASC of 2,000.
Great. Thanks.
That's kind of all. That's all that I would say.
Thanks for giving me a call. I'll call the head fellow over at the university. We'll work on getting this patient transferred, and then we can talk about other labs. Great. That was perfect. Okay, we have one more. Okay, so Mr. Q, he's a 61-year-old guy. He's got a history of hypertension. He came into the ED today with right upper quadrant pain and nausea and vomiting. Started within the past 24 hours. His vitals, his temperature is 38.2, his heart rate is 112, his blood pressure is 102/61, respiratory rate is 22. O2 is 95% on there. On exam, he looks like he's in pain, he's mild distress, but he's allergic with it. His heart's tachycardic, his lungs are clear. He does have right upper quadrant tenderness of palpation, but his abdomen's not distended, he doesn't have any rebound or guarding. He looks pretty jaundiced. You get some initial labs. Working on his skills here, so. And they look like this. Yes, he's got the loops. His right hand is 15,000. Obstructive pattern of what? Great. Yes. So he has a mixed pattern of liver injury. It's a predominantly cholestatic ulcer hepatocyte. That's perfect. Fever, right upper quadrant pain, jaundice, cholestatic liver injury, white count. What do you think he might have? Ascending cholangitis. Great. How did that diagnose him? Great. So I'm hearing MRCP, I'm hearing ERCP. This is great. So the technical diagnostic criteria are fever, chills, evidence of inflammation like elevated white count, elevated CRP, cholestatic injury, which we see on labs, and biliary obstruction, which we see on imaging. What kind of imaging do you want to order in this protein? Ultrasound. Great. Sensitive or specific for cholangitis? It's very specific. It's actually not very sensitive. A lot of it is because there are limitations to ultrasound with operator variability. People have a lot of bowel gas. It's hard to see things. So if you see biliary ductal dilatation, it is very specific. It's not sensitive. CT is both very sensitive and specific. Whenever I'm thinking about ultrasound versus CT, I think this patient has a reason I shouldn't give them a CT. The main reason usually is hemodynamic instability, right? Do I want to send them down to radiology multiple floors away? Do I want to send them with the nurse so that I can send them with transport? What do you think about this guy? Should he send him down for a CT or should he get an ultrasound knowing that maybe it's not going to tell you the truth? I agree. Yeah. He's swerving, he's not shocked. This is true. So what are you going to do for him? We're going to order a CT to confirm the diagnosis. It does show cholelithiasis, stones in the gallbladder, shows concern for choledocholithiasis, a stone at the common bile duct, and dilation of both his intrahepatic and extrahepatic biliary ducts. Cystic cholangitis based on these criteria. Great, he has all of these things. Fevers, white count, cholestatic injury on labs, biliary obstruction on imaging. So how are we going to treat it? Antibiotics, what are you going to choose? In general. Ceftriaxone, great. So we use a cephalosporin plus anaerobic coverage of flagyl. If you're worried about multi-drug resistant organisms, if patients are hospitalized a lot recently, there's a recent instrumentation, maybe you reach for the piptase and zosyn. For patients with community-acquired acute cholangitis, ceftriaxone is sufficient. And then we mentioned ERCP. We decide if someone needs an ERCP. Or how does GI decide? Call a consult, great. But what do they look at? Great, yeah. So oftentimes if there's a mechanical obstruction that you see, yes, they'll go for it. So part of how we treat cholangitis is risk stratification. So we divide into mild, moderate, severe. This is just a shot from up to date, but severe basically means you're in shock when you're on pressors, you're altered, hypoxic, oliguric or your creatinine's over 2, your INR is greater than 1.5, your platelets are under 100,000. Does he need any of these? No, I agree. Moderate is any of the 2 of the following: abnormal white count, fever of at least 39, age of at least 75, Billy at least 5, or low albumin. Need that? Yeah, agreed. His white count is 15,000, his Billy is 6.3, so he needs moderate. And then mild means you have none of those things. So patients with severe cholangitis have an ERCP now. Patients with mild to moderate You start with medical management, but you go to ERCP if medical management is not working. So are you gonna call GI now for this patient? No, I agree. So you're gonna give him fluids. He's coming in with SIRS and a suspected source of infection. You give him 30 cc's per kg of fluid bolus. You start him on ceftriaxone and Flagyl. For a few hours, it's better. His heart rate is better. He feels a little better. But suddenly then his blood pressure is 80s over 40s. Call GI. Great. Call GI. Yes. And then what are you gonna say? Great. It's now worsening. I'm worried. Awesome. So we talked a little bit about when to call consultants, which is the limitations of our own knowledge of our own skills and doing procedures we don't do. Talk about the person who does the procedure is the person who decides if the patient needs a procedure. Talk a little bit about the urgency of calling consults when it's appropriate to re-page a fellow. And we went through basic management of the GI bleed, diagnostic criteria for liver failure, and noting the patients with acute liver failure needed urgent hepatology consult to listen for transplant. Then we reviewed how you diagnose acute cholangitis and when patients with cholangitis need ERC. Questions? Great. Well, thank you guys. Sorry about the short conference today, so I have to get over to you. So you're free to do whatever. You're actually 30 minutes. Thank you, Sam. You're welcome.